Thanks very much. Ed, could you just give me a thumbs up that you can see my presentation? We're all good? Yep, great. Well, thank you so much for inviting me, and hello everybody, good afternoon. Very quick introduction to myself and therefore the topic. I was part of a small team that was responsible for one part of the Topol review. Now, I don't have time this afternoon to cover the Topol review itself. I'm going to assume that many of you know about it, but the quick summary is that the Topol review is a very significant, perhaps even a kind of seminal review for the NHS about what we need to do right across the healthcare workforce in terms of workforce planning, in terms of training, to deliver the digital future. And on the day that the Topol review was launched in February 2019, Secretary of State Matt Hancock announced the creation of the Topol Digital Fellowship Scheme. And 4 months after this announcement, I found myself responsible for the design and delivery of the programme, which launched in September 2019. And I'm really here to share just a little bit of the story of the programme. What have we learned? What have the fellows done? What have they achieved? And I guess just touching on the title of today's event, the kind of shared decision-making that I think I'm likely to be commenting on is more shared decision-making, shared design decision-making at the pathway or service design level, rather than, I'm not one of the digital fellows myself, rather than at the clinician patient level. So with that intro, let's get cracking. So the last time I was in Oxford, for work anyway, was as part of the work on the Topol review, where on a day where we met various people, we met with Trish Greenhaw, who we were very influenced by in some of the reading we were doing prior to writing our part of the Topol review. And in particular, we were very influenced by her team's work on why most health tech initiatives fail. And you can see at the bottom right here, the kind of seminal paper, which introduced a framework for why most health tech initiatives fail. But the quick summary of that framework is that too often these initiatives are projects and not services. They're pet projects. They're too often the preserve of an enthusiast and not of a team, or not certainly of the organization. They're too often not attentive to how to scale up. In other words, they're not attentive to becoming a project. They kind of stay in pilot mode and the enthusiasm goes elsewhere. And therefore they don't become sustainable. And that influence, the influence of this argument really fed into the design of the digital fellowship program. And we didn't want to add to the list of failed small-scale digital health initiatives. So when we designed the digital health fellowship program, at the absolute core is the first bullet point here, which is that the actual work to seek to make digital change happen is the core. It's not a kind of side project. It's not an add-on. It's not something to sort of do a little bit of research about as a side project to an academic program. So we kind of stripped things back to protect time. We fund up to 2 days of protected time, currently for 12 months for the digital fellows, to progress a digital health initiative. And anything else that's part of the program is really to surround that, I'll call it a project, to surround and progress and support the digital health initiative. So it's that workshop program which exposes the fellows to thinking about digital service development, to companies, to experts that have done this. And often this is thinking from outside the health service, but thankfully it's thinking that's taking root more and more inside the service about how to develop a person-centered digital service. So that was the workshop program. We also, as you can see here, we mandated that fellows learn about machine learning and service design, not something that's going to go away. So we didn't apologize for exposing all of our fellows to ideas about machine learning and service design and delivery. We didn't mandate that they work on machine learning, but that they need to know these ideas. And very importantly, particularly for our current cohort, the facilitated online community for the fellows is fundamental. So the next slide is really is a slide that we use and have used when we've said to the fellows, this is what your program is about, because we say again and again, right at the very start, the core of the program is the project. And it's the progress you can make with the time you've been given and the support that surrounds you to make that digital health initiative stick as much as it can. And what I'm showing you here before I go and talk about what we've kind of learned from all of that work, this is actually a sticker on my laptop that we all got a copy of at one of our cohort 1 workshops from one of the workshop providers that really articulates very briefly, very succinctly, some of the thinking about digital services development that we're exposing our fellows to. That, you know, and maybe this goes back to my point about shared decision making, that teams developing services in support of understood user needs lead the way. It's not about the deployment of the technology. The more we can deploy teams, the more the teams understand user needs, the better the decision making, the more the clinical digital service will take root. So what, moving on now, has been achieved by the fellows, and what have you learned from their experiences? Well, first of all, the range of achievements is really broad. There's a small strain across cohort 1. We're on our second cohort now. Cohort 1 finished in January. Cohort 1, a cohort running right through the middle of the pandemic, or the pandemic running right through the middle of cohort 1. We've seen fellows that have developed remote monitoring services in diabetic eye care, diabetic foot care, remote monitoring services for patients with macular disease, with rheumatoid arthritis. Going to comment on a few shortly. We've seen fellows set up or contribute to the development of a pan-London AI centre for healthcare. We've had fellows working more on the kind of education, workforce development side, developing, and this one I would really advocate that people look out for, and I'll mention links shortly, a national digital competency framework for allied health professionals. But actually, if you look at that framework, it's very much, these are the things we all need to be aware of, whether we're an AHP, a clinical scientist, a pharmacist, a dentist, a doctor. And in response to COVID, so many of our fellows saw the opportunity and didn't just deliver their own project, but really stepped up and led the introduction of remote monitoring, virtual clinics, digital services for and beyond their own trust. And if I was to, if you very briefly said, well, where are the greatest successes? And I read over in preparation for today the summaries that all of the fellows have written, and they're all online, point you to them shortly. The greatest successes by the digital fellows occurred where these things at least were in place, that there was, or another way of summarizing this is that the greater the institutional commitment and the more there was a team in place seeking to create a service and not to deploy a technology, and the more that there was solid and ongoing connection with users, often patients in their needs, the greater the success was of the initiatives that the fellows were working on. And I'm now going to very quickly step through the examples of 4 of these fellows super briefly, not because they're the best, but actually these are just 4 that fit the bill that I've just kind of listed for you there, but also to show you the range of work that the fellows have done. And I've taken screenshots from the Topol website, which I will refer you to later, where all of their writing up of their projects is contained. So here's Melanie Martin, who worked on remote monitoring for PROMs in rheumatoid arthritis patients, a service that's conducted back and forward between patient and clinicians and the clinical team via text messaging, a service which seeks intelligence on patient health to keep the healthy patients out of hospital and release capacity for the more needy, a service that was developed very intimately working with an external team of web developers, very intimate and repeated connection with service users to inform the development of the product. And thinking about some of the titles or the talks that we've already had, Mohammed's title was about, can digital decision systems are they only impersonal? This is an initiative where I think the exact opposite is in place, in that the data that is exchanged via this very simple service conducted via the patient's smartphone allows for tremendous personalization. We don't have to stack up the patients in a queue in the hospital or even in the virtual queue for the clinic, because we know where the well patients are and where the less well patients are. Another example, Sarum, Oxford-based actually, a web-based self-assessment training service for people tasked with reviewing medical images. Again, there was extensive working with a development team. I'm going to keep using that word team a lot today, repeatedly testing and getting feedback for improvements on this extremely impressive service. Roxanne, head of research nursing at Moorfields Eye Hospital, working to try to reach the very hard to reach, the people who have not attended clinic in hospital for the diabetic eye screening, and trying to improve that by taking the screening service out into the community, using a mobile device to capture and submit images, receive results in situ. Roxanne, again, it's a team effort, trained teams of nurses and others and GP practices out in the community. There was collaboration also in this team with the app supplier. So there's the industrial partner as well, and extensive kind of testing and feedback and iteration in the early stages of that effort, which is still ongoing, and therefore more than likely to become a service and not a pet project. And finally, Tim, who's Warwick based and probably known to several of you on the call today, initially came into the Topol Programme, again with another remote monitoring project, again using a smartphone for patients to submit images of their feet for assessment and monitoring and support. Again, close collaboration with the app supplier, again working in a broad multidisciplinary team. And Tim's also got a list, which I can't go into today, of other digital initiatives in multidisciplinary teams in response to COVID-19 that grew out of and were embedded at university hospitals, Coventry and Warwickshire. So, you know, those kind of characteristics of the shared teamwork, not just the clinician and others, the clinician and digital specialists, the clinician, the multidisciplinary clinical team working on these projects. And one of where I want to finish is on what I'm going to call system learning from the experiences of our fellows, because, you know, we unleashed a bunch of enthusiasts, and you know, Trish Greenhaw's work clearly suggests that enthusiasts aren't enough, but that is what we did. And we supported and we unleashed enthusiasts, but we wanted to learn carefully about their experiences on the ground. We wanted to learn about what is it like to try to lead digital health change in the NHS. And if enthusiasts are not enough, what else do we need to address and to make the change happen? So we commissioned an excellent user research company, some of whose slides I'm going to pinch in what we're just about to see to finish. And this was to do some research, not about the programme, but to ask the fellows about their experience on the ground, in the trust, trying to knock on doors, trying to make things happen, to make their digital initiatives stick. And we've got a really comprehensive set of findings, and I'm only going to scratch the surface of it today with some of the more obvious or some of the bigger findings, but there's a handful to share to finish with today. And the first is stating probably the blatantly obvious, but COVID has been a huge opportunity. It really has advanced the digital health agenda hugely, but also there's a need to consolidate, to maybe strip back things that were done in a hurry and to secure and advance the right changes. And that's been a real focus and a finding right across the board when we've talked to the fellows who've advanced not only their own, but other colleagues' digital work. Here's a slide here we paused the fellowship from March to September, almost inevitably last year, and could have paused it again as the second and third waves took root. And we asked the fellows in September, so, I mean, it feels like such a long time ago. We said to them, only 6 months into the pandemic, you know, what progress has your service made in the last 6 months? And look at these figures. These are 47% saying this has changed, that it's not going back. Or a third of them saying it's been really fast, it's been really radical. It's been so much easier to get off the ground. We used to think that the barriers were concrete, as one of them said to me during this session, but we discovered they were cardboard. And in the research project, simple quotation, that the COVID situation really has moved the digital agenda forwards decades. But the fellows also said to us, and this is more about the programme, but it's also about the way in which they worked in their trusts, that being part of a multidisciplinary community has been almost the thing they valued highly. That's both the community of each other, the community of the fellowship, but the community that we've made possible for them to join by buying their time out so that they can go and embed themselves with teams. And that multidisciplinarity came through again and again in the research that we did. And there's a quotation here, I know you can all read, I'm not going to read it to you, about how also some of our fellows felt this multidisciplinarity. We're still a stranger to it in so many places, and we could do more of it in order to move digital change forward. The next set of findings, no great kind of rocket science here, and in fact they kind of echo the Trish Greenhaw team's paper, which is that it's the organizational and it's the cultural factors that can really make or break digital change. And we found many, and I'm only listing 3 here, but in particular, the greater the local leadership buy-in, the greater the success. The greater the investment in the infrastructure and in the teams, the greater the success. And one of the recurrent issues that we encountered was a kind of, that we encouraged a kind of, let's say, an internet first, a digital first mindset, which is often about agile development, developing in small increments, learning, getting feedback on your small increments to move things forward, and how that was almost out of kilter with the kind of hierarchical, try and know everything before you do it structure of the NHS. And there's 3 quotations I'm going to share but not read, just as a way of sort of helping you get a sense of some of the things we found from unleashing these enthusiasts into these organizational and cultural minefields that they had to navigate. Here's one that said it was, we struggled because the infrastructure isn't there for us to really take advantage of the data work we want to do or the team working we want to advance. Here's another about, again, infrastructure. The more we're looking at, and it probably goes back to Enda's presentation from 2 presentations ago, very much about joined-upness, that joined-upness of the patient data. Mo, again, talking about this. We haven't got that. The more we've got that, the easier we can build on top of. And there's back to that point about that kind of culture clash between the sort of culture of the digital economy and maybe the culture of the health economy, and how we're rubbing them up against each other, and it's quite interesting to see where that lands. And a final point really for now is that we talked to the fellows particularly towards the end of the cohort, and they effectively said to us that NHS lacks sufficient integrated training opportunities for digital health clinicians. We need pathways to make this kind of work the primary purpose of certain groups of clinical professionals, because there's plenty that want to take advantage of it, not just some isolated kind of enthusiasts clubs. And it's something that I'm sharing with you because as I can hear the tension between what we've unleashed enthusiasts, and yet the research says enthusiasts are not enough. Their experience says enthusiasts are not enough. So we've wanted to conduct this research so that the way we support fellows, but also the fellowship itself, can, as we develop it, connect hopefully better to other career opportunities, or we're going to advocate for better digital career pathways because we've gained this experience. We've invested as a system in these people, and this is what we've found, and we want to spread the story of where the barriers or where the gaps still are, so that we get better at filling those gaps and supporting other healthcare professionals to progress along digital career pathways. I hope that's proved interesting, and there's a final quotation which kind of summarizes that. I'm very, very happy, obviously, for people to contact us. I would advocate that you look at the Topol website, which is topol.he.nhs.uk, where you can read summaries from each of our cohort 1 fellows, and you can find out what our cohort 2 is working on, double the size of cohort 1, and doing some extremely interesting work. But for now, thank you very much, and happy to contribute to any of the discussion and the questions to follow.